assistant professor. That's fine. You're so funny. Okay, so here we are. And let's see, who do we have on the phone? We have, Mike Levy. Hi, Michael. Michael's in Boston now. You're in Boston now, right, Michael?
I am. I just moved this summer.
Oh, congratulations, Mazel Tov. I think we're coming to see you and Jamie and everybody with Teresa, God willing. So I'm looking forward to that. Hi, Scott. Scott Newsom's on, and that's all great. And Ashley Lucas, our MS Neurology PA extraordinaire, and of course Alex Cruz. We'll wait a couple of minutes. It's 4:45, but good. So Michael, I'm sure it was in play for quite a long time, but I was for some reason very surprised. So is anybody sort of taken over the Mike Levy TMNMO clinic, or is it just getting folded into the whole thing?
Well, you know, Hopkins, there are always great trainees ready to fill the gaps.
Of course, yes.
Do you know Elias Sotirkos?
Yes, wonderful.
Been a fellow at Hopkins. He's going to move into that position, and he's got great mentors like Scott Newsom on the call now, along with Sid and Ellen and Arun.
That is wonderful. That is wonderful. And thanks for tuning in. And maybe we should have a little chat offline at some point. I'd like to talk to you about the editorial process with N2 and other things, and maybe interested in a little bit closer ties and collaboration on this and the writing. So you seem to be very interested. So I think that would be awesome. Was that Uncle Bobby that just got on?
That is c'est moi, as Miss Piggy would say.
There it is. Hi,
I'm having trouble with the internet thing, so I have already done.
All right, so Elliot, we are at 2 minutes past.
The hospital gets
sound fine. It's great. Can you hear us? Can you hear us?
I can hear you. I can hear you.
Wonderful. Okay, so Doris, I think in the interest of time, we always seem to have lots to say. It's only a couple minutes, but I'm sure we'll have more join. But maybe you want to begin and introduce the new webinar series for the academic year 2019-20. So Doris, take it away.
I'm sorry, give me 1 second. I am responding to Michael, who's having trouble logging in. Okay, yep. All right, so welcome everyone. We are very excited to kick off the new year with you. I'm going to ask that unless you are presenting or getting ready to speak, please mute your lines. I will go through and mute all of the lines if I need to momentarily. But before we do that, so Elliot and I would definitely like to welcome the new members of the faculty this year who are joining us and will hopefully be contributing to the great conversation. So we have Robert Kane from Ascension Seton joining us, new this year. We also have, I'm sorry, go ahead.
In Austin, Texas.
Okay, excellent. We also have Oleg Komogortsev from Texas State University, the Department of Computer Science. My apologies if I mispronounce your last name, but he is new this year as well.
Yeah, and soon to be joint appointment in Professor of Neurology at UT Austin at the Dell Medical School as well.
Excellent. And then we also have Michael Racky joining us. He is the editor-in-chief of the journal Neuroimmunology, so we want to welcome him.
What's his name? I never heard of him.
Very funny. Well, you know, Mike,
couldn't resist.
Those of you who know my large stature, Mike Racky and I are identical twins, and this is an example of fetal-placental insufficiency. That's Racky. Go ahead, Doris. Uncle Bob knows what I'm talking about.
Whatever you say, Elliot. Yep. And then lastly, we want to welcome Natalia Ternopolska, who is the medical director at the MS Center at St. Luke's in Pennsylvania. And so welcome to her. And I think that covers the new members. And so with that, Elliot, is there anything that you would like to say before we turn this over to Jenny Feng, who is the Neuroimmunology Fellow at the Mellon Center for MS, who is one of our two presenters this evening?
Yeah, no, I just want to thank everybody for contributing and tuning in, and not only faculty, but folks who have been mentors and participated. So I'll specifically point out, of course, Mila Goldman, and I see Annette Okai is on. Hi, Annette. So thank you so much for tuning in. I think that's what makes this such a special program. And we look forward to another very exciting year. We had 4 papers appear in the new section of Neurology N2 last year from the National Multiple Sclerosis Society case conference proceedings. So we're very proud of that, and currently working on revisions of 5 submissions invited from last year, and hoping that with Dr. Dalmu's approval and with the help of Scott Zamville and my wife, Tree, we're hoping to see 2 of the case reports in each of the next 2 issues, God willing. And we look forward to a great year with presentations, again, worthy of more invitations to present these cases, which bring together some really important pearls and pitfalls. So it's great to be back. And Jenny, this is your 2nd year, right? You presented last year, right?
Yes, I did on the leukodystrophy case last year.
Fabulous. And that was amazing. And we're looking forward to seeing what you have to say this time. And given that you're still a fellow, that I can tell you that was one of the cases that we continue to vacillate on. It was so interesting. But the fact that you're a 2-year flyer means we can put that back in the hopper for consideration for publication as well. And I'm sure today you'll have another very interesting case for us to consider.
Sure.
So fire away. Thanks for joining us. We really appreciate you.
No problem. So I'm happy to present this case to everyone. For those of you who I guess weren't part of the conference last year, my name is Jenny Feng. I'm a 2nd-year neuroimmunology fellow at the Cleveland Clinic Mellon Center for MS. So without further ado, I'm just going to get started in the interest of time. So let me just make sure I get this working. Sorry. Okay. Oops. Okay. So I have a case of a 39-year-old male who is presenting to us. So this is from a few years back, who initially had came to us with difficulty walking, urinary incontinence, constipation, bilateral feet numbness, and significant fatigue. And if you dug into a little bit more into his history on what's been done before, we noticed that he had, at 29 years old, had a hemorrhagic stroke, and that was presumed in the setting of, due to like hypertension and excessive ibuprofen use in the setting of headaches back then. And then he recovered from that quite well. And then at 34 years old, he had another hemorrhagic stroke with a CT head scan that I'm showing here on the slide. At that time, he also recovered, and they really never found out the reason why he had these strokes. And then at 35 years old, that's when he started developing frequent falls and leg weakness and difficult walking. And this has continued to progress to worsen to a point where he needed to come all the way up to Cleveland to seek another second opinion. So based on the exam note from back when he first presented to us, he, at that time, I'm just highlighting the part, the red is the part that were found to be abnormal. So he has, otherwise mental status, cranial nerve, they were all normal, but, and then upper extremities were normal, except for mildly increased tone. But in the lower extremities, he's pretty much diffusely weak all over, with increased tone in right lower extremity that was more than the left, and he was hyperreflexic as well with bilateral upgoing toe, so lots of upper motor neuron signs back then. And he also has some dysmetria in the left upper extremity, also altered sensation that was able to be tracked to a T10 level. So at this time, he did have a imaging of his spine. So the MRI spine that were done around that time, you can see on the STIR sagittal image that there's a hyperintense lesion kind of towards the posterior part of the cord around this level. And I don't really have a good axial T2 cut for you, but I do have the STIR. And then the T1 post-contrast image, you can see there's a mild enhancement along the left lateral border of this lesion. And per the radiology reading for that.
Hold on, Jenny, on this one, you mean the right lateral border?
Oh yeah, sorry, right lateral border. I'm pointing to the wrong one.
That's just when we start putting left and right together with clinical. So go ahead. I'm sorry.
Go ahead, sorry.
Radiologists all have Gerstmann syndrome.
Yes, they do. But I know Jenny doesn't. So anyway, okay.
Yeah. So the radiology report, they did mention that they were seeing in the central cord. So apparently maybe they have better axial T2 cut, but the report said that there was T2 signal within the central cord at the level of T10 with enhancement. So for this one, after this imaging, the patient got IV steroids, which he did improve some afterwards, but not completely back to his baseline. He was still having trouble with gait difficulties, and this continued on after after he finished the course of IV steroids. He improved some, but the disabilities returned a few weeks after that. He did started having more increasing falls and more worsening gait difficulties. So MRI T-spine that was done again a couple months after the initial scan showed that there is still this T2 hyperintense lesion here, and here I have a little bit of a better axial cut. And you can see that it's mainly along the posterior aspect, kind of a patchy T2 hyperintense signal in the cord, and also you can see that there's also patchy enhancement throughout that area on the T1 post-contrast scan. So for this one, he received plasmapheresis for 5 courses, and he did improve partially again after this one, but not back to his baseline. So a few months later, he continued to have the full workup. So this was all done locally before he came to see us. So MRI scan of the brain was done. So I can pull up to the next slide showing you that. So the MRI scan showed just multiple areas of GRE, GRE signal, indicating that he has areas of just microhemorrhages throughout the brain, mostly along the border regions, not typically in the area where you expect for somebody who presumably had hypertension back when he's 29. And
Jenny,
then,
Bob, were you trying to chime in, Bob?
No, I thought we lost signal. I've got Jenny back.
My fault. Go ahead, Jenny. My fault. Go ahead.
Oh, okay. All right. But I'm going to pull up to this current slide showing you that he does, the radiology report did not mention this, but you can see that on the post-contrast T1 imaging, he had kind of diffuse kind of cerebral enhancement throughout the bilateral hemispheres. And this was a little bit unusual back then, but it wasn't commented on. And he had a CT of his chest that basically just showed some old granulomatous disease, but he didn't have any, adenopathy, didn't have any other areas of malignancies. And he had a cerebral angiogram that was normal. And he had a lumbar puncture that basically showed he had 5 whites, 34 protein, and 58 glucose. Nothing really kind of, standing out from something, nothing really standing out from what he was presenting with. And he had negative oligoclonal bands, and his IgG index was not elevated, it was 0.6. And his CSF ACE level was normal, and then all the infectious workup from the CSF, it did not really turn out to have anything. He had VEP scans, VEP studies, and SSEP of the upper extremities done that were normal. And blood work wise, some inflammatory factors, some rheumatoid factors, they were all negative, including ANA, TSH, ACE levels, NMO antibodies that were done, HIV, HTLV, those were all negative. And his SPEP did show some hypergamma-globulinemia without any M protein spike, and that was of unclear significance. So
can I ask a question at this point, Jenny?
Yeah, go ahead.
When they did the films on the T2s, the ones that pick up microbleeds, did he show anything given that history? I mean, hypertension and Motrin doesn't usually give you bleeds. And I'm thinking about whether he has some kind of inflammatory small vessels that now is showing up later on. But, most 29-year-olds taking Motrin, unless their blood pressure is like 250 over something,
Exactly.
they're not going to bleed.
Yeah,
Right.
exactly. So that was
because sometimes you can pick up those micro bleeds. You can see it in amyloid angiopathy. You can see it in some of the vasculitic syndromes where they will have these multiple little dots of increased signal on the T2.
Yeah, no, that was one of the points that I was gonna make later is that, he's a healthy 29-year-old, and with hypertension you accept bleeds more in the, than the deeper gray matter area, but his bleeds, as you can see, it's all around the lobar areas, which does bring the idea of, amyloid, but he also being somebody who was 29 years old at this time presentation, 39, so that was also a little bit unusual. So at this time, don't really have a clear, etiology for all these multiple hemorrhages.
Can I ask a quick question?
Yeah, go ahead.
A quick question? This is Scott Newsom.
Sure. Oh, hi, Scott.
Did he undergo a PET CT scan to evaluate the sort of nodules in his chest a little bit further?
At that time, no. Mm-hmm.
Okay. And then I may have missed this, but ANCA panel, was that done? And then also
at that time, no.
Some of the inflammatory markers, were those done prior to steroids and plasmapheresis?
No, at that time, no. I was trying to find the old records of that, but I didn't see any evidence of that being done. Mm-mm.
And ESR and CRP, to extend the last comment, because ANA, a lot of people just think ANA is, quote, a vasculitis screen, which is nonsense because it picks up certain diseases and a lot of non-specific. But ESRs and CRPs, unless you've recently had IVIG for the ESR, the CRP isn't affected. They're two of the most non-specific and most sensitive tests you can think of.
Yeah.
I'm just wondering again, with the hypergammaglobulinemia in the blood, again, unusual for a young person, unless it's left over from his IVIG. If he was pheresed after the IVIG, it shouldn't be. That makes you think about one of the more systemic vasculitides as a possibility. But you can see it obviously in meningitis with granulomatosis, previously known by the name of a doctor who shouldn't be mentioned, and some of the other related disorders. Sometimes even the ANCA sometimes don't help you.
Yeah. No, I totally agree.
Great point. Okay, Jenny.
Okay. So moving on. So after that last scan, the local team decided to start him on oral prednisone, 60 milligrams a day. He had some minimal improvement clinically and radiographically, but nothing really, nothing really outstanding. And then at that point, somebody mentioned the possibility of checking him for von Hippel-Lindau disease. And he underwent some workup for that, had renal ultrasound, had a more detailed eye exam and retinal angiogram, and those were negative. Then he had a repeat lumbar puncture.
This is Elliot. So for those who were on the phone and it's not, immediately apparent, so go ahead and give us just the quick and dirty 30 seconds on von Hippel-Lindau.
Sorry, say that again?
Could you give us the 30-second synopsis on von Hippel-Lindau for those who are on the line? It just doesn't come clear, Yeah.
Yeah, so von Hippel-Lindau is an inherited genetic disorder, basically. So when somebody is young presenting to you, you start thinking of with these weird syndrome, you start thinking about kind of genetic maybe etiology. Basically, it can present with basically tumors, cysts throughout the body. So for somebody with von Hippel-Lindau disease, you might expect like renal cysts. You might expect cysts in the on the retinal angiogram, and also maybe associated with cerebral cysts. So that's why somebody on the care team thought about checking him for that.
Okay, thank you. That's great. Fabulous.
No and okay, and then moving forward, he had another repeat LP. So this is a couple years after the initial one. Again, nothing really standing out. He had again negative oligoclonal bands. Myelin basic protein was normal, and had more infectious workup that were negative. And IgG index was 0.57. And this time he had a paraneoplastic antibody that were checked, and they were negative. And because of the the repeat hemorrhages and the interesting findings on the post-contrast MRI, we also sent for a hypercoagulable panel, and those are also negative, except for elevated fibrinogen and CRP. Repeat CT chest, again, showed that old granuloma in the left lower lobe, but again, no nodular infiltrates, no adenopathies, and he underwent PFTs that were also normal. So at this time, the pulmonary team that were evaluating him were pretty convinced that he did not have any pulmonary involvement of whatever this is. And
Jenny, it's Elliot again. Just one quick question. When you had shown very nicely the axial thoracic spinal cord, we knew about the T2 hyperintensity, but on the T1 axial with gadolinium, you nicely showed originally that right lateral area of enhancement, and then we came back later and there was still some patchy enhancement, including some in that right lateral area. So just, can you make just comment about the time between the scans and the relevance of persistent enhancement compared to, for example, in demyelinating disease?
Sure.
And what does that provoke in terms of your own thinking about persistent enhancement?
Sure. So, I mean, if you look at the scan from December 2011, so you can just see just a tiny bit of, right lateral enhancement here. But if you go to the scan, that's about 4 months later, and almost around, well, I mean, the cut's a little bit different, but you can see that there's a little bit more patching enhancement in that area on T1 post-contrast image. So for somebody with demyelinating disease, for example, you wouldn't expect this persistent enhancement, especially after he had steroids. And for somebody who had, worsening clinical syndrome after steroids and with persistent T1 enhancement, you start thinking about something that's not in the demyelinating realm, but maybe towards, either in a tumor category, the other kind of inflammatory disease category, or maybe persistent, infectious disease category if they have been untreated.
And included within that, very nice, thank you for that, but also within that, in terms of the spectrum of inflammatory etiologies, of course, would also be granulomatous inflammation. So it's very important. So thanks, that's a great explanation.
Sure.
Okay. And this is Scott. I'll say also in the setting of hypogammaglobulinemia, sarcoidosis, neurosarcoidosis, you'll often see that systemically. And also I'll mention vascular myelopathies, dural AV fistulas, you'll sometimes see persistent enhancement within the spinal cord, T2 signal change. And so we'll often use spinal angiograms to look at that.
And Jolene, yeah. Appreciate that, Scott. Thank you.
No, definitely. Those were on the different show. And then the idea of, somebody, the cavernous malformation was brought up because of the appearance of that persistent enhancement. So the MRI of the T-spine with GRE was done to look for hemosiderin deposits, but that was also negative. I don't have a good picture of that because it was done in the outside hospital, but you can trust my words.
And by the way, no bleeding in other organ systems like one might suspect in Rondeau-Osler-Weber or HHT or anything like that. This was all CNS restricted.
All CNS, yes.
Okay, thanks, Jenny.
And so fast forward a few years later, he did have some interval hemorrhages in the cerebrum on interval MRI scan. So here I have like an MRI from March, which showed that he has some in the cerebellum and then some in the basal ganglia region. And then I have a CT scan in October, a couple months after that, that's showing there's other new areas of interval hemorrhages. So so he had another course of IV steroids that also did not have any significant clinical improvement. But he continued to have this worsening gait. So by this time, he went from a cane to partially dependent on a wheelchair for ambulation. And now I have a MRI of the T-spine in 2018, 2 years after that scan. You can see that, okay, so the T2, so the hyperintensity, it's still there in T9, T10 region. And they're also on the T1, there's also some T1 hyperintensity as well. In T1 post-contrast image, you can see that this one's a little bit better quality. So you can see the enhancement is more posterior and involves the posterior portion of the core. But also you can maybe kind of convince yourself there's a little bit of meningeal involvement as well towards the end. And so now this is more recent time. So he's coming this is a more recent involvement of him at 42 years old now. So like I said, worsening lower extremity weakness, worsening urinary and bowel function. Now he's starting to have some memory impairments and headaches and slur speech as well. Strength-wise, is worse compared to back then when he was 39 years old. Again, upper motor neuron signs and like I said, spastic gait, ataxia, decreased vibration, and light touch in distal lower extremities. So everything's worse compared to before. And then I have an interesting MRI from most recently on the T1 post-contrast scan. I just want to show you guys that there's also that diffuse, patchy, kind of cerebral, diffuse involvement of the contrast agent, and they're also in different areas compared to what they were before a couple years ago when you saw the MRI post-con image. So,
can I ask a quick question? Was there discussion about doing a brain biopsy when there was that patchy enhancement within the brain to see if you could find out whether there was a small vessel vasculitis?
Yeah, so I was going to show the biopsy results next. I just wanted to pause here to see if anybody had any further thoughts before I show the past slides.
Okay, sorry.
No problem.
I mean, the one thing you could sort of say, what do all these lesions have in common? They're spread out all over the place, and so is vasculature.
Mm-hmm.
Yep.
Yeah. Okay.
Great point.
And they keep varying in location, and so.
Yeah,
Yeah.
Great point.
Okay, so I'm gonna just I can move ahead to the biopsy then. So these are the pictures from here. Okay, so these are the pictures from the pathology slides. One caveat I do have to mention was that because it was hard to find a target to biopsy, as you can see, from the MRI, this kind of contrast enhancement is kind of diffuse. It's really hard to just pick one area. So they just did like, a right frontal biopsy. So it's not clear whether they have captured all the, inflammatory parts or not. But this is what they found. So from what I can tell you, or can show you is that, so this is the white matter. This is a picture of the white matter. So there are two small non-necrotizing granulomas in there, and with some mild perivascular infiltrates. And some dura and the cortex were biopsied, and then they didn't see any signs of inflammation in those slices. So this is mainly in the white matter that they biopsied in the right frontal lobe.
And then this little loop.
Okay. Okay. So I move forward to the next slide. So we did a soluble IL-2 receptor antibody, and that was 1747, which is elevated above normal. At this time, ANCA was done, and also proteinase 3 antibodies, MPO antibodies, they were negative. And then CRP was elevated, ESR was mildly elevated, and a 3T MRA of the brain was done that showed vessel wall enhancement in multiple small to medium intracranial vessels, suggestive of vasculitis. Yep. So the final diagnosis, taking all of this together, was that he had small vessel vasculitis, secondary to CNS sarcoidosis. If no further comments, going to move forward to his management plan.
So the sarcoidosis is based on the fact that it was granulomatous and in the vessels?
Yeah, the the vessels and the granuloma. Although other things can cause granulomas as well, but
and
also
vasculitis, including a disease called granulomatosis with angiitis, previously known as Wegener's.
Yeah.
They don't have central as much as they have peripheral and cranial nerve takeoff, but you sort of need a piece of tissue from an area that's not been involved that might show you the granuloma without angiitis, like his lung or a lymph node.
Yeah, and because the talk about biopsying that cord lesion was mentioned, but there's
that's not a great idea.
Yeah,
but he had some stuff in his lung which may be unrelated, but it's something to go after. And if you found a non-caseating granuloma with no vasculitic component, then you'd say, well, this is sarcoid, and so is the one in the brain. But the lack of an ANCA doesn't make it not granulomatous with angiitis.
Yeah. But the soluble IL-2 receptor did point us towards a more kind of towards the sarcoidosis workup, and the fact that he had vasculitic changes in both the brain and also the spinal cord, kind of also cuts down our differential a little bit.
I agree that the latter, the distribution with the spinal cord, I think makes the what we used to call Wegener's less likely. I'd be careful about cytokines, because there's nothing specific about IL-2 elevation, ACE elevation, IL-6 elevation. They're just signs of inflammation. So sarcoid may be the most common, but I wonder if we could ever find a series on IL-2 or IL-2 antibodies, either one, in biopsy-proven Wegener's. I'll bet there isn't one. So you got to be a little careful.
Sure, definitely.
Jenny, this is Elliot. You might be getting to this, and to extend Bob's point just for a sec, and that is, when you looked at this, what did you find in terms of the literature, in terms of intravascular non-caseating granulomatous inflammation and that differential in terms of presenting as a true small vessel vasculitis with, again, non-caseating granulomatous disease, and when it is sarcoid? Were there many out there that you could find?
No, I mean, just the fact, in terms of like non-caseating granulomatous etiology associated with the small vessel vasculitis, there's a lot of case reports, but not that many that were, that were pattern forming. So there are a few of,
Oh, hold on, somebody's got to turn off their audio, but can you just repeat what you just said about, pattern forming?
Yeah, no, I just say there's nothing that's clearly pointing to one thing or another, but sarcoidosis is definitely one of the potential causes. But on top of that, like I said, with there are the other different causes for sure. So not just sarcoidosis.
Go ahead.
Can you hear me?
Yes.
Oh, Jenny, this is Mila Goldman. I think, was it true as you go back to that this was relatively refractory to steroids?
Yeah.
And did you discuss that being sort of an atypical feature as you think about sarcoid as a diagnosis?
So the thought was that initially when he first developed the gait difficulties, he had a high dose IV steroids that did improve his symptoms initially. So that part, because sarcoidosis is usually very responsive to steroids.
Exactly.
Yeah, and then the part that the initial course of steroid did help him for some period of time before he relapsed again. So that part did agree with the diagnosed sarcoidosis, but the subsequent episodes that did not improve, and those were thought to be maybe because he already had the damage from the previous T10 lesion that just never resolved, and those are just old damages that that steroid didn't help very much.
It's pretty clear that I agree that sarcoid usually with the first episode steroids work, although lack of or response to is always dangerous unless it's gout and culture seed. But they do some of them become resistant, and that's why you see methotrexate, azathioprine, anti-TNF alpha used widely. And there's a beautiful article from the UCSF group on it's a review, it's not prospective, but I've got a few patients who are on TNF alpha inhibitors because azathioprine plus methotrexate plus steroids didn't work. So they don't. It doesn't cure everybody.
Yeah.
Yeah. No, I was just going to follow up. This is Mila. I agree with that. I think the one thing I always think is helpful, though, is when you have multiple elements of a story or a presentation or a situation that are atypical, that when you add them all together, is there something that you need to be paying attention to or missing? So not responsive to steroids in and of itself wouldn't challenge the sarcoid diagnosis, but you have these other elements, you start to ask, is there more than one thing going on? And so I think you just have to see how it hangs together.
Yeah,
and you have multiple elements where you're, kind of trying to explain it. So I think that's just one more piece that could be something to just pay attention to.
I mean, you're going to wind up using very similar agents anyway. There's no more material to do FIME tests to prove that it's, quote, sarcoid. And you can have ANCA negative vasculitics. And, the therapy, as Jenny was saying, is going to be pretty similar. If you have somebody who's steroid resistant with any of these syndromes, with or without pheresis or IVIG, the next step is the immunosuppressive agents. And now the monoclonals, and that's exactly what Jenny has laid out there.
Mm-hmm. And let's not forget that the other arbiter is time. And as time goes forward, the ability to obviously very judiciously follow patients and see if you don't have adequate control, what comes up in other tissues. It's another opportunity, whether it's skin or we end up seeing an arrhythmia or other factors that may help refine your thinking. But I think this is a beautiful case, and it's very well laid out and makes it unusual as the vasculitic component with strokes involvement. And more people need to be aware of that. So this is going to be a very compelling case, Jenny, for us to really consider to showcase in the N2 sections. So very well.
Yeah, and this is Scott Newsom, if I could make a couple real quick comments. So we see a fair amount of neurosarcoid at Hopkins, and I can't remember the last case that I saw that had intracranial hemorrhages associated with it. And so when I see intracranial hemorrhages and potentially a myelopathy, we start to think about a vasculitis. And granulomatous angiitis, I think we have to consider it being a different sort of entity than neurosarcoid, because it's clearly a vasculitis, whether it's driven by something that's similar to neurosarcoid or like Bob said, with respect to an ANCA-related vasculitic process. I just want to remind people also, granulomatous or granulomas on pathology, they can form just with inflammation. So it's not specific to sarcoidosis, even though, when you read the textbooks, it's like, oh yeah, this has to be sarcoid in that setting, but just inflammation by itself can cause granulomas. So no, this is a beautiful case.
So can foreign bodies. I mean, so can foreign bodies.
Yeah. No, I think the important aspect was that, since the biopsy, we only saw 2 granulomas, but overall, I think it did establish that there was some vessel wall inflammation demonstrating this is a case of vasculitis. And, even though we don't have like a slam dunk diagnosis, but moving towards treatment maybe is the next best plan to trying to improve the patient from deteriorating.
And it's the working diagnosis till it doesn't work anymore.
Yeah. Yes.
Yeah, no, and I think someone had mentioned like steroid responsive. For me is another clue. I mean, early on in neurosarcoidosis, these patients are typically, very steroid responsive, albeit they need to be on a maintenance immunosuppressant therapy, but they're very responsive to that. And if you have sort of a steroid unresponsive case, then you have to shift your attention to, one of the mimickers. And with that imaging pattern, again, multiple distribution, arterial distributions, vasculitis certainly is a consideration. And then I'll just make one last comment and then I'll shut up. For biopsy, you may be aware of this technique called black blood imaging, black blood MRI imaging, which helps you isolate out vessels to go for a biopsy. There's not a lot of centers or places that do this. But when you have such diffuse disease and you're like, well, where do I biopsy? Black blood MRI is sometimes helpful.
Thank you for that.
Pat Moore used to.
Fascinating.
Pat Moore always used to say, while they're doing the biopsy, since they have to go through the meninges on the way in and way out, they ought to take a little piece because occasionally you will pick up in some of the granulomatous angiitis in the meninges, even if there's not enhancement. And there's no harm in doing it, basically, because you got to go through it and back out.
Absolutely.
So Pat just always insist on that.
Yeah.
Okay, so Jenny, are you additional comments?
No, I was gonna move forward towards some clinical pearls and what happened with this patient afterward. Okay.
Let's go ahead.
So this patient was started on azathioprine, 50 milligrams BID, which is a pretty common medication that you go for, after somebody who did not respond to steroids, who has, vasculitis, and then for whatever it's worth, his pain did improve after a week being on this, and then now the plan is to add infliximab to his treatment plan on top of azathioprine, because of the severe involvement of both, cerebrum and the spinal cord. And here I just have some, just a few slides on distinguish, for myelitis, due to MS, and we talked about a little before with MS and MO, ADEM, so they worsen over days to weeks, and then the enhancement doesn't persist, and then people do have some, element of recovery after that. But myelitis due to other etiologies such as sarcoidosis or dural AV fistulas, you can have you have clinical deterioration that can continue for longer and sometimes over a month. And then in our patient, this has, he had persistent enhancement and this persistent T2 hyperintensity that pretty much remained during his entire course here. So isolated neurosarcoidosis, yes.
I'm sorry, it's Doris. I just wanted to interject. There's a comment in the comment box from Mark. Can someone comment on the utility of the soluble IL-2 receptor?
And I think Bob Listak commented on that. Bob, you want to reiterate what you had to say about?
Well, I mean, I know that it's recognized that can be seen with sarcoid, but just you can also see it elevated in the blood and CSF in MS. I mean, not in that high a range, but it's not specific. It's the same with IL-6. There are certain, like in transverse myelitis, they usually are very high. And we know from the old work of Doug Kerr when he was at Hopkins about the role of IL-6 in myelitis. But I'd be very careful about any of these things being disease-specific. And ACE may be the best example. I mean, ACE is made by inflammatory cells, microglia in the nervous system, because they're macrophages and macrophages. So, yes, sarcoid, as an example, is the most common cause of an ACE increase, including in the CSF. But if you have activated microglia, there's no reason, for some other reason, that they can't be making ACE. And in fact, Larry Steinman's work looking at gene expression and protein, the ACE receptor type 2 was up in the MS plaques because microglia are activated. So I'd be very careful about a single, maybe VEGF and POEMS, but there are very few where, an elevation tells you anything other than there's inflammation, other than statistical, and by itself, without the rest of this nice picture that Jenny laid out, it tells you it's inflammatory, which is useful, obviously, especially with the oligoclonal bands and IgG index being normal. This is a good example of something systemically inflammatory going on, and I think it's useful that way because you want to always ask: are you dealing with a disease that is inflammatory, limited to the nervous system, or is it a systemic disease in which the nervous system is the canary in the coal mine where it hits first? And I think Jenny has a comment in there about spinal cord and sarcoid is sometimes the way it presents. And we've seen quite a few of them, and the Mayo Clinic has published a lot, and so the Hopkins in New Maryland. When Walter Royal was up there, he was working with Barney Stern on some of these projects. So again, be very careful. There's nothing. There's nothing that's 100% specific in human biology.
Yeah. As long as we have on the line very quickly, Mike Levy, Professor Levy, any comment about the IL-6 story with myelitis? I think Bob alluded to this briefly, but I have you here, so maybe you and maybe Scotty could make some comment about the IL-6, the Doug Kerr story that you guys have been looking at. So how should we look at IL-6 and myelitis?
Well, in Doug's study, he captured a few cases during an acute relapse of TM and found very, very high levels. But then there were some cases with normal levels of IL-6. It's difficult to get correctly because these cytokine assays are a little bit finicky, and if the sample sits out at room temperature for a little bit of time, that IL-6 would degrade and you can't capture it. So I think the receptor is a better marker than the itself. The other thing I'll say is in an NMO, there are nice studies that demonstrate that IL-6 is responsible for driving the plasmablast differentiation and production of the aquaporin-4 antibody, and that led to the trial for satralizumab, which is like an extended-release tocilizumab in NMO, which showed positive results. So I think there's definitely a role for IL-6 in these kinds.
Thank you so much for that. Okay, so Jenny, I'm going to let you continue to completion so we can get to our second one. But this is a great discussion, and you fomented it, Jenny. So this is even better than last year, and you were great last year.
Oh, thank you. Yeah, I just have like a few more slides to go. And so like spinal cord sarcoidosis, usually from what I'm reading in the literature, usually the first manifestation of CNS sarcoidosis. And I have a few pictures of the typical imaging findings that you might see. But one thing is that it does show persistent gadolinium enhancement as opposed to some of the other causes from more the auto the demyelinating causes of myelitis. And then it's common in the cervical and thoracic cord, but can also happen in the intramedullary regions and the leptomeningeal regions. And this is just a nice table showing the different type of findings on the spinal cord imaging that can help you differentiate between, myelitis due to MS, due to infarction, and, versus sarcoidosis or, paraneoplastic myelopathy. And here's some typical findings. So usually sarcoidosis, this is what I show here is the trident sign. So you can kind of trace out the T1 post-contrast imaging, and that kind of looks like a trident, and also the central canal enhancement. So this is what you typically see in a neurosarcoidosis involving the spinal cord. Although in our patient it wasn't as clear, but I think I can kind of convince myself that he had a little bit of this, not so much the central canal, but like the trident sign. I can convince myself to see a little bit of that on one of the prior imaging. And then this is this is what it looks like on the sagittal view. And some of the clinical pearls, so neurosarcoidosis granulomas usually in the vicinity of the blood vessel, so that's why sometimes they can be associated with perivascular inflammation. And it is a procoagulable state in that you can have small ischemia, you can have ischemia from small vessel vasculitis, and also you can have intracranial hemorrhage for the very same reason. And the spinal cord involvement is thought to be due to the extension of the inflammatory factors through the perivascular spaces.
Hey, Jenny, could you go back one slide? Just go back one slide. I just wanted to also point out very beautifully on the left in panel E, you can also see there where you see very significant cord expansion, inflammation, and in the context of a small spinal canal or congenital stenosis, you could see how you potentially could even embarrass the vasa corona and infarct that way due to compression. So let's not forget that part of it. We see the enhancement, but that cord is expanded quite significantly. Yeah, thanks.
Yeah, and then for our patient, he did have some mild cord expansion at the T10 level as well. That was mentioned in the report. Okay, and then here's just I guess like a flow chart published from one of our groups here at the Sarcoidosis Center at Cleveland Clinic on just the management aspect of neurosarcoidosis. So usually you would start with something like prednisone, and then if patient have moderate or severe disease, you might considering adding something like steroid-sparing agents and or go on to infliximab. And here, so some of the steroid-sparing agents, azathioprine, one of the most commonly used, and then followed by methotrexate, and then the mycophenolate mofetil, CellCept, which is not very commonly used in neurosarcoidosis, but some case report did find some help with that. But usually azathioprine, methotrexate are the more common ones. And then if patients that do have severe disease course or do not respond to azathioprine, you can consider adding an anti-TNF alpha antibody. For example, infliximab is one of the more common ones, but adalimumab has been mentioned. So, but just be aware that occasionally they can cause CNS demyelinating disease as a as like a side effect, and also there's liver toxicity associated with these medications. But these are some of the more common things used to treat. So for our patient, he was on azathioprine, and we're adding on infliximab for his treatment. So hopefully we'll be able to see some improvement in him. And
I would also mention that the TNF alpha inhibitors also can cause peripheral nerve demyelination. So CIDP-like syndromes have been reported.
That's a good point.
Great point. Not just CNS, but also peripheral. So Jenny, that is fabulous. And I think in the interest of time, Doris, I think we'll boot up and transition to our second. But thank you. Very provocative. Great discussion by lots of people. Really greatly appreciate that. And keep up the great work. Patients lucky to have you.
Great. Thank you.
All right. Excellent. Thanks, Jenny. Michael, I'm going to go ahead and make you presenter, and let's see if we can get it to work. And if not, I do have your slides ready to go, and I can queue them up for you. All right, and while he gets his slides ready, Michael is the fellow over at USC. And so this is your second year, correct, in your fellowship? There we go.
Okay, can you hear me?
We can hear you, and we can see you, and we see your desktop.
Welcome. Thanks, Michael.
Only a little bit of had to completely reinstall GoToMeeting to get here.
Oh, that was fun.
Hopefully things are going to work out in a second. Let me see if I can get my slides up. Yeah, I'm finishing up my second year of a Sylvia Lowry Fellowship, so working on master's and research methods and doing research in comorbidities while also taking care of these fascinating patients.
Congratulations.
Welcome. I'm going to mute myself, and I will let you take it away.
Okay. So I wanted to show a case today that I think is interesting about some questions on this spinal cord that we had for patients that we had quite a big debate on, and I got to eat a little bit of humble pie towards the end of it, so I think it's a good case to share for that reason. Let me just close this out. I won't be able to see the text thing, but so this is a 45-year-old right-handed African-American female who was carrying a diagnosis of MS since 2015, now having chronic paraplegia since 2017, who presented to our hospital for worsening spasticity, pain, and bladder incontinence. Going back to kind of give a history of her initial diagnosis, she developed new onset numbness followed by weakness that she says started in her left foot and spread up her leg and then across her body with a sensory level around her pelvis over the course of, she doesn't remember the exact time frame, but several days to a week. Did not have any bowel or bladder involvement at that time in 2015. She did seek care at an outside facility where they received an MRI, and they also performed a lumbar puncture, of which we did not have the results of, but she was told that the results of both of those evaluations were consistent with the diagnosis of multiple sclerosis. She did receive steroids during that hospitalizations, but reports she really didn't feel like she improved a whole lot. She had chronic numbness since then, though she was able to walk independently after that hospitalization. She did have motor fatigue where her endurance was never the same compared to what she was before that event in 2015. She was followed by a neurologist as an outpatient and was started on dimethyl fumarate. And she remained on that medication until she was admitted to our facility. She reports during that time frame that she had what she referred to as relapses, though they had quite variable descriptions of what the symptoms were, and many of them didn't actually last 24 hours. It was unclear whether they were ever associated with infections, but she described them as having like muscle cramps, itching, numbness, weakness, pain and pain. So unclear that she ever had another clear acute attack that lasted longer than 24 hours without infections, but had certainly numerous chronic symptoms that fluctuated significantly that were neurologic invasives. She never changed her DMT and did report good adherence to the dimethyl fumarate. Then in 2017, she had a second event which was confounded a little bit by a preceding fall. So she was at a friend's house and she fell ground level, landed on her back on a tile floor. She was able to stand up and walk home after the fall, was at her new baseline since 2015. Didn't notice any immediate effects from the fall, though a few weeks later, she developed subacute to chronic worsening of her weakness and numbness in her legs, leading up to not being able to walk, as well as increased muscle cramps and new bowel and bladder incontinence, as well as new arm weakness, so that the weakness actually was now at a higher level and more severe in the legs. She was again admitted to another hospital where they repeated spinal cord imaging and found reportedly a cervical compression fracture that was, they felt, impinging on the cord, and she actually underwent rather urgent fusion and decompression at the level of C6 and C7. She's never walked since that hospitalization. She has chronic symptoms that include pain, spasticity, for which she takes baclofen and gabapentin for, and she's paraplegic. She uses a motorized scooter around at home and to get by, and she has chronic urinary incontinence. Though before hospitalization in our facility, she did still have sensory urge to urinate when she needed to. Then 4 months prior to when she was admitted to our hospital, she was admitted to another hospital and was reportedly having another enhancing spinal cord lesion, and she received steroids and a diagnosis of an MS relapse at that hospital. She felt like she did not significantly improve with the steroids, and she was now having worsening symptoms and significant pain from tonic muscle spasms, back pain, worsening of her incontinence. She could no longer feel the urge to urinate when she came to our hospital. So she was admitted to our facility, and we're going to go through quite a few images, and we were consulted after her initial imaging to comment on the results of that. Her review of systems was essentially negative outside of what I've described. So briefly, her exam before we actually look at the fun part of this case. She had intact visual fields, no real visual acuity or relative apheric pupillary defect, no evidence of a prior optic neuritis. Her eye movements were all intact. Rest cranial nerves were really intact. She had pretty good strength in the upper extremities, 5 out of 5s, with the exception of maybe a little bit weaker on the grip on the left, though she was right-handed. But then she was profoundly weak in her legs, 0 out of 5 in the hip flexion, maybe 1 out of 5 in adduction and abduction, no knee extension, no knee flexion. She could get some toe wiggle, but couldn't even really move all of her ankle, even not against gravity. She had significantly reduced temperature sensation in the right arm, as well as gross sensory loss in both legs. Separate from the actual kind of numbness and having difficulty with sensation in her legs, she did have significant hyperesthesia on the right when she had pressure, so trying to lift her legs to try to isolate muscles then caused kind of a burning neuropathic pain in her right leg. She had 2+ reflexes in the left arm, which was the upper extremity that had mostly good strength, but then she was 3+ basically everywhere else. And she had non-sustained clonus on the left ankle and sustained clonus in the right ankle. She had upgoing toes bilaterally, which is not surprising. She had intact fingers with no cerebellar signs in the upper extremities, obviously couldn't test it in the lower extremities. So this is some of the imaging that she received when she was in the emergency room being admitted in our facility. And obviously you can see quite an extensive region of T2 signal abnormality consistent edema and really expansile lesion in the cord here that it's actually kind of filling the defect from her prior surgery. And then she did have contrast enhancements really at the core of that center area. And then this is right at the C6 level to give you an axial view. And incidentally, this enhancement, or maybe not incidentally, and when we kind of review the whole case at the end, this enhancement is right at the level of her prior surgery. And so that was one point of interest as we reviewed these with the neuroradiologist. Her MRI brain just included 2 slices, but these are quite representative of what her MRI brain looked like. And I think we always see in radiology reports, they will comment on in normal brain MRIs unremarkable, but I would say in this case, it was remarkably normal, that she was who carried a diagnosis of multiple sclerosis for 4 years, that this was a big red flag that we've been dealing with the wrong diagnosis. So given her extensive lesion in the spinal cord and what sounded like either recurrent myelitis inflammation or a persistent enhancing lesion and an almost normal brain MRI, we became quite concerned right away that this was not multiple sclerosis. There was a significant differential diagnosis that included recurrent longitudinally extensive transverse myelitis. Initially on the MRI report, they proposed possibly a surgical complication that was leading to chronic damage to the spinal cord. Spinal cord infarct was listed on the differential. To throw it out there, related to the last presentation, sarcoidosis or granulomatous disease was discussed, as well as tumor. And so, the reports from the neuroradiologists were kind of classic hedging their bets. And so depending on which person you went and talked to, I think they actually were having debates. Some of them felt that this was likely tumor, and others felt quite strongly that they thought that this was more inflammatory in nature, and we were getting both of those feedbacks from the neuroradiologists. Some of our initial laboratory, yeah.
I was just going to make a quick comment, which you'll get to. With these longitudinally extensive myelopathies, often with the differentials that you went through, at least for an inflammatory or an infectious etiology, you often see more hazy enhancement pattern throughout the cord versus sort of this focal, hyper-intense enhancement pattern that's right at the level of what seemingly is a maximum stenosis. So I'll leave it at that, but I'm sure you'll enlighten us later.
So she did have some basic. What was that?
We're getting feedback on your line, Michael. Are you on the phone as well?
No,
okay.
I'm actually not.
All right, give me 1 second.
Volume, maybe.
Okay, try again.
Okay. So her initial laboratory evaluation was relatively normal with her basic CBC and CMP. She had a mild anemia, which wasn't at a level that was concerning. Her basic inflammatory markers were all within normal limits, including ESR, CRP, ANA, ANCA, SSA, SSB. She had ACE, and then she had some B12 and folate checked. She had some send-out labs, including NMO and MOG sent because of the longitudinally extensive nature of the lesion. And then she did have the spinal tap early on in her course, which showed a normal white blood cell count and not unexpected red blood cell counts. She had normal glucose, normal protein, PCR was negative, culture, cytology, IgG index, and oligoclonal bands were all sent and were pending as their send-outs or delayed through pathology. So while we were waiting for more of those results, she was because there was no clear evidence of an infection, we did treat her with steroids initially, and this is imaging after 5 days of 1,000 milligrams of methylprednisolone daily. And so you see here on the left in the T2, while there's still quite a bit of edema and lesion, it's definitely shorter than it was before. It used to come all the way really up to C3, so it did have some T2 improvement, and the enhancement really reduced markedly, though there is a little bit of linear enhancement still there. And then this is that same C6 level compared to what I showed you before. And so we did see significant improvement from an MRI standpoint after 5 days of steroids, though her exam really remained unchanged, except she did have improvement in her muscle spasms and hyperesthesia, though that was also being treated symptomatically with muscle relaxants as well as gabapentin. So at this point, we had new results to compare to that MRI, and her CSF culture was negative, cytology was negative, and she did have positive oligoclonal bands, 3 unique bands in the CSF not seen in the serum. And so at this point, because there was still a significant T2 burden there, and there really wasn't much improvement in her exam, there was a large discussion of whether we should pursue a biopsy at this point, whether we should continue trying to treat it empirically while we waited for the antibodies and other tests to come back negative. So I'm kind of interested what other people might comment on at this point, given this amount of history.
Actually, that's a great point to punctuate at this point, Michael. You've already declared the fact that you had some egg on your face, and I've had egg on my face innumerable times. But let's move it around and ask a few folks. Alex, I have our superlative fellow here at UT Austin at Dell, Alex Cruz. Alex, what's your take on this? There's a differential, but we've got some bands. We've got a surgical site. We have a lesion that's associated. He's put it out with steroids. He still has some phasogenic changes, but what's your thinking? And smart people reserve the right to change their minds. So you can tell us what you think, and we'll learn more as we go.
Well, I guess right at the beginning was concerned about maybe
feedback,
like maybe trauma related or.
Alex, go ahead and try again. I'm going to try muting some of the phone lines because I think that's contributing to.
He's now using mine, okay. Doris. So let's see how it goes.
No, I was just at the beginning. I was thinking that it could be maybe trauma related, just kind of like that zigzag S line, you know, and the amount of vasogenic edema, like kind of superiorly and inferiorly, kind of that's what I kind of thought. I don't know if that's somebody else has like something else.
And I think let's be careful that the presence of bands and other findings can also be secondary to an inflammatory ictus, secondary to trauma. So it's not always going to necessarily be autoimmune disease or a specific infectious etiology. As you know, and I know, it tells us something, but the specificity is always problematic when we're looking at issues like antibody synthesis. Annette, are you still with us? Annette O'Kai. Annette, what's your take on this particular set of circumstances where just because we have surgical procedure adjacent to an area of hyperintensity enhancement, and just because we've abolished a lot of that with corticosteroids and anti-inflammatory, doesn't necessarily mean that that's an underlying autoimmune disease or even an infectious process, or trauma. Could be many things. Any other clues or hints in this case that that would help you think about what the underlying etiology here would be?
Well, my first diagnosis will still be, it could be a structural cause because of where the lesion is directly at the site of her prior surgery. And even though there were some other areas involved above and below, it was still continuous as opposed to discontiguous. So could it be that with that one area which became inflamed, could be from, you know, just the structural, the instability of that area causing an inflammation, and you see it expanding above and below.
Yeah.
The fact that her
I'm sorry, go ahead. Sorry.
The fact that her brain MRI did not show anything, and I didn't, was a thoracic spine MRI done? I did not see that as well to look for other areas.
Yes, it was done, but this is the only significant lesion seen.
Yeah.
Okay. So I'm still skeptical about other causes, other autoimmune or causes of this until I can prove otherwise. The steroids, yes, will calm down any kind of inflammation and reduce that. But when you look at the pre and post steroids, it's still centered around that area. So I will like to see something else before moving away from the diagnosis as a structural cause of this.
Yeah. So we might have egg on our face together.
We may.
I
Especially
concur with you 100%. I concur with you. Bring
and
it, Mike.
He did warn us in the beginning that we may have eggs on our face.
I'm with you.
That's a fascinating thing, because there was one neuroradiologist who was adamantly in your camp. So I will say that you were not alone in your thinking at this institution as well, though there were definitely the general neurology team was actually the ones pushing for a biopsy and were concerned most about tumor. And we are, the neuroimmunology team, were a bunch of hammers looking at nails, really thinking that this was inflammatory. So I'll tell you what I was thinking at the time is that I did not think it was a surgical complication, because if you recall, the surgery was in 2017 and she had initial symptoms in 2015. And so I was bothered by, if you're looking for a unifying diagnosis, that she had an episode of symptoms several years before she ever had that surgery. And the fact that she got up after the fall, and that the actual surgery and diagnosis was not until a couple weeks later seemed a little different than odd for a traumatic spinal cord injury. I was actually concerned that they did surgery on a misdiagnosis of maybe there was a compression fracture, but maybe the lesion was there first, making it look like the compression fracture actually was causing spinal cord problems. Did not think that this was a spinal cord infarct at this point, mainly because of the time frame. Both episodes where she got worse were subacute to chronic, whereas spinal cord infarcts typically appear in more acute to hyperacute episodes like typical stroke, even though they're not a typical stroke syndrome themselves. And left on kind of our differential was a recurrent longitudinally extensive transverse myelitis, like maybe an NMOSD, though we're still pending any antibodies, and she hadn't had any localization outside of the spinal cord, which is a little bit of a red flag for that. Sarcoidosis or another inflammatory disease or tumor was still kind of on our differential at this point. And we pushed for empiric treatment while we waited for antibodies, because when we're talking about a spinal cord biopsy, we just felt that it would be a real shame to have a biopsy show inflammation and then an antibody come back positive a week after you cut into her spinal cord. And so that was our argument, that we weren't saying she wasn't going to need a biopsy, but that we wanted to get the non-invasive tests first, especially when you're talking about a spinal cord biopsy, that although she has chronic disability could still have the potential for making things more permanent if this ends up being a treatable disease. And so she received 5 days of plasmapheresis and then was re-imaged, and this is that imaging afterwards. So a little bit more of the same in that it got a little bit better than after the steroids with the T2, and though post-contrast, she did still have some abnormalities in the axial, and the sagittal, she has a lot of artifact on this one, but some improvement in the contrast enhancement as well. Labs came back during that time frame. Her exam remained unchanged. She really did not get any improvement from any of our therapies, and her aquaporin 4 and MOG antibodies both returned negative. We did have the outside MRI from 4 months before, not from 2017 or 2015. And at this point, I'll give you the MRIs kind of all lined up as a timeline so you can really take a look at them, but we did ultimately consult neurosurgery for a biopsy. So starting on the far left here, this was from the outside hospital when she received steroids. It's unclear to me whether this is pre or post steroids at that hospital, but I think pre-steroids. So that lesion right at the center where she had the surgery is still there. And then in just 4 months time frame, went from this small lesion to this really extensive and expansile lesion, which was at my time making me more convinced that this might be inflammatory. It's just that short time frames to get that much worse. Then she got the steroids, it got a little bit better. Then she got the Plex, it got a little bit better.
Hey, Michael, hold on 1 second. Doris, can you unmute Bob Lissack? He's trying to make a comment and he's off. So let's, it's beautiful, Michael. Just hold on 1 second. I know Bob wanted to say something.
All right,
I wanted to point out that,
there we go.
Okay.
that corticosteroids are anti-edema, not just anti-inflammation.
Okay.
And in the old days when we had crude brain scans, sometimes you put a patient who you thought had a tumor on corticosteroids while you worked them up for primary versus secondary, because imaging wasn't that good to decide glioma versus mets. And then sometimes the patient would do so well, you'd go back and repeat the brain scan. And if you didn't know technetium, if you didn't know where the lesion was before, you might have missed it. So again, this could be anti-edema. That doesn't mean anti-inflammation. That's why failure to respond to steroids and response to steroids are very non-specific, so be careful.
Okay,
and then interesting, as part of the biopsy planning, we got this next MRI. So this is STAS post plasmapheresis, and then 4 days after this MRI, it's already notably worse again. And then this is the same time line with the post-contrast images. So really not a lot of contrast enhancement seen on the outside MRI, then more centralized along the lesion, a little bit better with the steroids, still some there persistent though after the plasmapheresis. And then notably worse just in 4 days after removal of the plasmapheresis. And so now I think we're ready for
Michael, before you go on,
this was a low-grade astrocytoma.
Yeah, go ahead. Yeah.
And what was that? Is that just me again?
Well, the only point, Elliot, the only point I was going to make is as that's coming and going, the one thing that I felt was conspicuously not present is steroids, anti-inflammatory, anti-edema, that what we didn't really see was really any evidence much in the way of any cavitary degeneration, if it was like a more severe process. But obviously, a low-grade glioma may not be that destructive at that phase. But that was one thing I was struck by, is that over time, we're not seeing cavitary change in terms of tissue destruction. But you're going to talk about that now because of the grade.
Yeah, and so this was a low-grade astrocytoma, which when kind of reviewing, it has actually more consistent outcomes with her case than I realized at the time. My kind of experience with significant spinal cord tumors up to this point have been actually GBMs, which are a little bit less common, but so you watch those people just deteriorate rapidly. So the fact that she had been experiencing this since 2015 made me kind of question whether it was really going to be a spinal cord tumor. But they can actually have quite long durations with these low-grade astrocytomas. So just kind of reviewing the kind of multiple misdiagnoses that she went through first in 2015, why it wasn't MS. I think that we in this group can all readily see that, but I think it's important to remember that people get misdiagnosed a lot, and so when they come with pre-existing diagnosis, we don't get to just hang our hats on that. In retrospect, she clearly never had a acute demyelinating event. I think in 2015 that was the beginning of her spinal cord actually causing permanent damage to the cells there. So I'll say I didn't just take that history from her charts, that I took that from her. She really does give a subacute event that could be convincing for a demyelinating event. So I don't discredit someone for thinking that that was a transverse myelitis, but certainly the normal brain MRI with that extensive of spinal cord lesion, I think, was a red flag right away. And then the fact that she just never improved and never responded to typical treatments also was a red flag. And so touching base, what we were kind of thinking about is maybe this is NMOSD early on. We did send for both those antibodies, but to be clear, without the antibodies, you have to have two core clinical characteristics to diagnose NMOSD that's antibody negative, and she clearly would not meet that diagnosis because the only syndromes she ever had were spinal cord syndromes, and then she's antibody negative, so she cannot meet this diagnostic criteria. And so then we kind of think about why should we have maybe been thinking about tumor faster in her case. So just kind of some basic information on spinal cord tumors and when we should be thinking about it. They're pretty rare. They're 2 to 4% of all primary CNS tumors, and as we know, primary CNS tumors are already not the most common presentation of CNS tumors, and metastases far outrank them in commonality. And then of those, ependymomas, which have typically very good outcomes with full resection, make up about 50% of the primary, and this is excluding meningiomas. I should specify that this is for intramedullary, intradural tumors. And then astrocytomas make up about 30% of these tumors. So astrocytomas specifically typically present as a chronic presentation rather than a acute presentation, and it's very marked in the expansile cord lesions. That's a very common finding in spinal cord tumors. So I think when we're looking at how this is even filling up some of that void from the surgery and just really wanting to expand and take up space, that's something that should raise eyebrows. Certainly it can be seen in other things besides tumor, but it's certainly something that should put it on your differential. Significant T2 edema, which we definitely saw, is also very common in these tumors, and I think that's exactly why we saw a change in the T2 signal with steroids and plasmapheresis. They were ultimately acting as an anti-edema treatment. And then structural syrinxes occur in about 40% of these lesions, and so a big expansile lesion with a syrinx should definitely put that on your differential. They're typically T1 iso to hypointense, which this, looking back, I guess I don't have pre-contrast scans, but if you look at the post-contrast scans up where the rest of the expansile lesion was, they're fairly iso-intense. And then T2 hyperintense, which is almost everything. And unfortunately, I really was looking to try to find that real solid knots of enhancement here in this lesion, I was like, should that have really raised our red flag? But it really isn't specific. These tumors have highly variable enhancement patterns, and so in several review articles, they really don't identify any particular pattern of enhancement that can make you concerned about tumors in general. The thing that really, we know they're non-specific, but I was surprised to see the oligoclonal bands in a tumor, and there was not a lot of literature observing this, but there are several other case reports of oligoclonal bands in the CSF resulting in treatment for myelitis that was later proven to be a tumor. One of them was an ependymoma. One of them was actually a cavernoma, which is not really a malignancy, but and so it's important to remember that oligoclonal bands are useful, but they're not specific to one disease, and they can be a marker of inflammation in general, which tumors can cause. And the more and more we think about how they're treating cancer these days with checkpoint inhibitors and immunotherapies, it's actually important to think about that the immune system is involved in your own innate anti-cancer mechanism. So it may very well have been having some CNS production of antibodies there because of the tumor, and that they weren't, it's not an incidental finding, but that actually it was because of the pathology and inflammation going on around.
Very good point.
And so the kind of lesson that I think it was learned through kind of these multiple misdiagnoses that she experiences, in almost all of our diagnostic criteria, whether it's for MS or NMO, there's always this line of that there's no better explanation for the clinical presentation. You have to rule out other things. And I think that's an underappreciated component of the diagnostic criteria. And certainly this experience is going to keep me humble and always thinking about that extra differential diagnosis and what we might be missing before we just assume that it's an inflammatory lesion and treat it that way. So these are the references I put up, and just kind of open discussion talking about her prognosis in the astrocytoma. So I mentioned that my experience has been mostly with like glioblastomas, and those patients do exceedingly poorly. But the actually 5-year survival rate for these low-grade astrocytomas in the spinal cord is over 80%. And so it's very common for these people to be a chronic presentation and to continue to progress very slowly. And so there's been some neurosurgical case reports of people who are as severe as her of actually just like having cornectomies to actually get a gross total resection because they're already completely paraplegic, though I don't think that's anywhere near a standard of care. Just thought it was an interesting case series. Most people don't undergo extensive resection within the spinal cord, especially if they have any function in the lower limbs residually. The primary treatment for these tumors is radiotherapy and then plus minus temozolomide.
Yeah. Michael, can you make some comment about issues of low-grade transformation to higher grade? Do you think in some of these series that the attempted resection, notwithstanding the benefit of radiotherapy, may have been related to concerns about subsequent later remote transformation to higher grade that actually could kill the patient?
Yeah, certainly. I think that while the 5-year survival rate is high in these low-grade astrocytomas, one of the neuro-oncologists that I trained with in residency kind of pretty much counseled every patient that, especially if they were young, like this patient was, someday this is going to transform. Someday this is going to kill you. It might not be today, it might not be where we're going to be here this whole time, but this is not going away. And I think a majority of these do eventually transform. I don't know the data on the spinal cord. Certainly, I think that's relatively true in brain tumors. And I don't think the data would be significantly different in spinal cords, though I can't quote that to you.
Yeah, thanks. That's very helpful. That's really well done, and I really appreciate your approach on the issue of it's about getting it right and being self-deprecating. So I think in that same spirit, I think Annette and I should decide how we'd like our eggs prepared. But we're
scrambled, well done.
Yeah, that was very well done, Michael. Any other comments from the field? I noticed, Doris, that not only Michael, but the team were about 2 minutes early. I don't think that's happened this is our third year.
Ever?
In the 3 years. In the 3 years Tree and I have been at the helm here with Uncle Bobby, I don't think we've ever done that. I've got to give most of the credit to Michael. He kept it moving, and Jenny did a great job. But any other final comments from the field?
I have unmuted your line, Bob. There you go.
Wish everybody good rest of the week, and for those who observe, Lashana Tova.
Yeah. Thank you, Bob.
All right, signing off. Dina's got dinner ready for me. I'll speak to you guys later. Bye.
Beautiful job, Michael. Thank you so much.
Thank you.
Yep.
Have a good week.
Thanks. Wonderful.
Bye-bye.
All right. Well, thank you, everyone. Thank you, Michael and Jenny, for great presentations. And it will be posted shortly for anyone who wants to watch it again. Thank you.
Great. Thank you.